Okay, great. Welcome. Thank you, everybody, for joining us. This is Snapshot session 4. My name is Lori Regenstreif, and I'm the moderator for this session. And before I introduce our speakers and we start the session, just a couple of reminders. You can increase the size of the slide presentation by right-clicking on the presentation image and clicking Picture-in-Picture and resizing the pop-out window. This is a snapshot session, and that means we have 3 presentations, all in the theme of emergency departments and hospital care. After each presentation, I'll spend a minute or two on any questions that come up at the end of the particular session in the chat, and then we'll move to the next presentation. And then after the presentations, we'll have a discussion period with all of the presenters. At that time, you'll be able to ask questions using your microphone, by raising your hand, or by using the chat, and I can read them out for you. So now I'll introduce the first presenter of the session. Dr. Ceire Storey is an FRCP emergency medicine resident at Queen's University with plans to complete an addiction medicine fellowship in her final year of study. She aspires to make an emergency department a safer place for those dealing with substance use disorders and improve care pathways. So thanks for welcoming her. She'll be presenting on barriers and facilitators to implementing ED-initiated buprenorphine.
Can everybody hear me?
Yes.
Okay, so thank you for the warm welcome. As mentioned, I'm Ceire Storey, and I'm a PGY4 emergent resident here in Kingston. And I'll be talking about barriers and facilitators to implementing emergency department initiated buprenorphine. I do want to say a special thanks to Dr. Jennifer Wyman and Susan Hum for their help with this presentation. So I did receive some support from the Women's College Hospital in the form of logistical support with data analysis, as well as the preparation for this presentation. And I do not have any conflicts of interest to disclose. I received a small stipend being the resident lead at the Kingston site for the Changemakers pilot project. So I hope you guys are able to, by the end of this presentation, recognize the relationship between knowledge, skills, belief, and resources in implementing practice change, to understand the experience of leaders in supporting their teams with the implementation of the ED pathway for people who use opioids, and to consider strategies to support these ED leaders in initiating and maintaining changes in the care for people who use substances. So patients with opioid use disorder often only access healthcare when they present to the emergency department with opioid-related complications. When buprenorphine treatment for opioid withdrawal and opioid use disorder is initiated in the emergency department, patients are twice as likely to connect with addictions treatment compared to just receiving a referral alone. Yet few ED physicians initiate buprenorphine on a regular basis. So to address this gap in care, Medify provided support to 5 teams across Ontario to pilot the implementation of a care pathway that would include both buprenorphine initiation and a direct referral to the local rapid access addictions medicine clinics. So implementation support included a small amount of funding to support the local ED leads, structured needs assessment, a comprehensive toolkit, regular meetings with members of the core team, educational materials, and easy access to ED experts. In order to better understand the factors impacting the implementation of the pathway, there were 7 semi-structured interviews that were conducted with the site leads. So these site leads included physicians, resident, nurse champion, and system navigators to explore both the barriers as well as the facilitators and their experience with leadership. As mentioned, I was lucky enough to be chosen as the resident lead for the Kingston site, and this gave me firsthand experience of the barriers and facilitators to initiating change within our healthcare system, and to see how profound the stigma faced by people who use substances negatively impacts their care. The barriers identified during these interviews were competing needs and priorities in the emergency department, resources and time, process challenges, stigma around addictions, RAM clinic accessibility, and inconsistent administrative and institutional support. So the pilot was initiated in June of 2021 in the midst of the COVID-19 pandemic. Staffing challenges such as staff shortages, staff turnover, and junior staff, as well as overwhelming ED volumes and burnout, all contributed to less willingness to incorporate new protocols and increased difficulty in managing the competing needs and priorities within our department. The amount of time required to go through the process of initiating buprenorphine was identified as a challenge, which was compounded by the fact that the initiation was done infrequently and therefore was not routine. When buprenorphine is used infrequently, keeping the protocols and orders set in mind is more difficult. An unanticipated challenge was the prevalence of patients that were presenting to our emergency departments with recent fentanyl use, or they were already on methadone, and this buprenorphine initiation protocol was deemed inappropriate. Unsurprisingly, but also disappointingly, judgmental attitudes towards people who use substances on the part of physicians and nursing staff were identified as implicit reasons that teams were less likely to be enthusiastic about implementing these buprenorphine protocols. Difficulty ensuring timely outpatient follow-up care after buprenorphine initiation was identified as a challenge. Although it wasn't clear how much this impacted the likelihood of medication initiation, some providers did comment that they were directing patients to the community OAT clinics where they were able to get more timely access. While some sites experienced positive support from their medical directors and department heads, other leads felt that they had little administrative support, leading to delays and significant frustrations. So some facilitators that were identified in the initiation of the buprenorphine pathway were clinical tools and resources, logistical supports, internal supports, and interprofessional collaboration, as well as local education initiatives. Although some organizations had buprenorphine order sets already in place, the MedFi clinical tools and resources were seen as being very helpful. In particular, it was the algorithms, the patient handouts, and the referral forms to community care that were deemed most useful. Participation in the project helped to increase awareness of buprenorphine as a treatment option in the emergency department, and also to formalize a process that was happening quite inconsistently. Having local champions facilitated the completion of order sets and a variety of local education initiatives, and support from the MedFi through regular meetings, resource sharing, and peer support from the Changemaker team itself, with monthly meetings, learning about the trials, the tribulations, and the successes of other sites, effectively created a community of practice that was seen as quite helpful. Both formal and informal leadership and mentorship were felt to be important to keep awareness up and provide support to the less experienced physicians. Conversations between the ED providers, including the nursing staff and the physician staff, were seen as helpful in keeping buprenorphine and substance use more generally active topics for discussion in the department. Training and education with physicians and nursing teams through grand rounds, lunch and learns, self-learning modules were considered to be very important in decreasing apprehension around prescribing buprenorphine. Different types of education, such as onboarding for new staff and ongoing education to keep awareness up, was seen as critical to helping teams to recognize and begin to dispel stigma towards people who use substances. Implementation of new clinical programs always requires planning to address gaps in knowledge, skills, and confidence, as well as consideration of environmental context and resources that can either support or hinder change. Offering a variety of educational sessions in different formats were considered to be important to increasing knowledge, but access to in-the-moment mentorship was particularly important in assisting clinicians to implement these new tools. So regular check-ins, positive feedback, and role modeling were all found to reinforce intentions and beliefs about people's capabilities. In the emergency department, it's not surprising that competing priorities were highlighted as a barrier to change. However, multiple comments suggest that the negative attitudes towards people who use drugs impact what was deemed a priority in the emergency department. On the other hand, education about substance use, stigma, and the evidence for treatment appear to be important factors in helping both nursing staff and physicians to identify their own biases, to seek care for people who use drugs as part of their professional role, and feel more optimistic about these interventions. Several leads commented that seeing colleagues modify their attitudes and approaches to people struggling with substance use was perhaps one of the most valuable parts of this project overall. Given what will undoubtedly be an ongoing concern about emergency department resources, several leaders advocated for designated roles within our departments as substance use navigators who would keep up the momentum for change by providing prompts, supporting and counseling patients about medications, and connecting them to community resources. So teams seeking to implement addictions clinical pathways need to be prepared for challenges. The progression from concept to active pathway is not linear, and as I'm sure you all know, happens in frustratingly slow steps. Extra time spent at the beginning of a project developing partnerships is well worth it. At the same time, unexpected benefits can arise from these programs. So one site had created a residency rotation in addictions medicine during this time period, and another site actually developed a hospital-wide program for buprenorphine initiation. For successful implementation of new addiction care pathways, tools and formal education sessions are important, but are not sufficient to stimulate change. Having local champions is vital for managing administrative tasks, building intra and interprofessional collaborations, and maintaining momentum. Thank you.
Thanks, Kira. That was great. I wonder if there's any questions for Kira. Whoops, sorry. Before we go to our next presenters, I'm just looking in the chat. It's interesting that you've noted something I think we all have also seen, those of us who've tried to get programs going in a hospital context, and that is having champions, local champions. Oh, I just saw a hand up. I think that was Jennifer. Jennifer, is that your hand?
Unintentionally.
Oh, okay. I was just saying that, yeah, so having somebody who's administratively strong in the setting, in the hospital setting or the program setting is really helpful for us, because we just often will feel like we have too many balls in the air. Oh, that is not your hand. It's just a hand that's over your head. Okay, so I think it might be, is it Miguel? There's sort of a crowding of faces, so I can't see whose hand is up, but please feel free to speak out. Looks like it's somebody, unless it's Trish. Whoever's got their hand up, would you like to speak up, ask a question? Maybe somebody's accidentally put up their hand. Oh.
Hi, Ceire. I wondered if you thought that this process is quicker to get Suboxone going in Emerge overall versus the process that I heard Tim did at his hospital, where he was help going down to emerge and starting it himself and walking people through it and then walking away?
I think a combination of both. So here at our site in Kingston, what we tried to do was with this funding, as you mentioned, kind of walking down yourself and doing it yourself. I think that's great, but we really tried to push the education piece. So it's great if myself and the others who are already trained to do this can walk down to emerge and just do it ourselves, but that's not going to create change within our whole department if we're not available, if we're not on shift. So instead of just walking down and doing it yourself, I think it would be important to include whichever emerge staff had kind of consulted you or reached out to ask for help, because this isn't something that's difficult to do. People are just scared to do it because they don't have the education and they're not sure how to do it. So if we can go down and show them how to do it, I think it's going to have a ripple effect down the road with more people being able to do it themselves.
Okay. Yeah, Trish has her hand up.
So, there we go. I just wanted to say one of the things that I'm doing is kind of a mix of both of them, so that my colleagues that are in the emerge will call me and then will put their phone on speakerphone, and I will walk the patient and the emerge doc through it, so that both of them are getting the education at the same time. They're better able to just get started the next time on their own because they've seen me do it. And obviously it only works when I have time to take the call, but it's been incredible. It seems to be working fairly well, in case that gets to be an option for anybody else. But we've got a very small emerge, so that's a big part of it.
Thanks. Okay, well, thanks, Kira. If there's any more questions that people come up with, you can save them and we can have them at the end. We'll have everybody on stage to answer more questions for the discussion period. So thanks. And we'll just get Robert and Zayya on. Great. Welcome. And thanks very much. Zayya Zendo, I'm going to introduce our two speakers. Zayya Zendo is currently a fourth-year medical student at the Schulich School of Medicine and Dentistry. Zayya's particular interest lies in quality improvement within healthcare. For example, he recently conducted a joint project applying a mixed method strategy and assessment of a safe injection site. Zayya aspires to bridge the gap between research and compassionate care, emphasizing the importance of informed decision-making in healthcare. And Robert McKay is a physician and addiction specialist in the Windsor-Essex region. He served as chief of the emergency department and occasionally oversees the ICU. Dr. McKay served as president of the Erie St. Clair Clinic, an addiction medicine clinic with 7 physicians. His passion for addiction medicine continues to drive his involvement with the addiction practice at that clinic. And since 2008, Dr. McKay has provided addiction medicine consults for complex pain patients and those with addiction disorders. And in 2021, he spearheaded the formation of a call group of 3 physicians to address addiction-related issues within the Windsor hospital system. Thanks.
All right, thank you. So hello, everyone. My name is Zayya, and I'm joined by Dr. Robert McKay, and today we'll be discussing our chart review study, which explored the rates of referral to addiction medicine for patients with opioid use disorders while they were admitted to inpatient services in Windsor, Ontario. So this project received financial support from the WeSpark Health Institute in the form of the Igniting Discovery Grant, which is a health research innovation grant for projects in the Windsor-Essex area. The project also received in-kind support from Windsor Regional Hospital in the form of decision support staff in pulling patient lists which fit our study criteria from the hospital EMR, and there's no applicable conflicts of interest to report. Both Dr. McKay and myself are recipients of the WeSpark Igniting Discovery Grant. Also, Dr. McKay holds privileges at Windsor Regional Hospital and Hotel Duke Grace Healthcare Tayford campus in Windsor. So the goals for this talk are as follows. Number one, be able to understand opioid use disorders in the context of a large community hospital center like Windsor. Also to gain some insight into the pathway that patients with opioid use disorders take through their stay in hospital. And finally, to appreciate the gap in care for people with opioid use disorders in accessing appropriate care while in hospital. So in terms of what we'll go over, first we'll just do a quick overview of the problem from a national and local perspective. Then we'll highlight the role of addiction medicine. And then we'll discuss the study itself in terms of the questions, the methods, and what our initial findings were. And finally, just a quick discussion on our findings, limitations, and the next steps. So I'm sure as many of you here are familiar with, and just to provide quick background, there's a growing calls to reduce pressures on our healthcare system and to support individuals who have opioid use disorders. So since the Public Health Agency of Canada began its surveillance in 2016, there's been significant uptrend in the rate of opioid use-related harms. So between 2016 and 2022, there's been about 36,233 hospitalizations due to opioid-related poisonings. This averages to about 12 to 14 hospitalizations per day, with an average length of admission about 3 days long. In the same time period, there was 36,442 apparent opioid toxicity deaths in Canada. And when we compare the 2016 to 2022 numbers, so in 2016, there was just under 3,000 deaths, with 87% being reported as accidental and 9 intentional. In 2022, there was over 7,000 deaths, with 97% being reported as accidental and 2% as intentional. Also, in 2022, 80% of the accidental opioid-related deaths were from non-pharmaceutical agents. So there also appeared to be an increase in these trends between 2019 and 2022, corresponding to around the same time as the onset of COVID. So there was around a 73% increase in opioid-related deaths and a 24% increase in opioid-related hospitalizations. So it can kind of be teased out in these trends, and it was touched on by PAC in their June 2023 joint statement. A significant amount of these harms appear to stem from unintentional complications of non-pharmaceutical opiate supply, and that individuals with opioid use disorders that are at a higher risk of being negatively impacted by social and economic stress. So looking at the local context of our study, so Windsor, Essex is an area with a population of just around 422,000 per the 2021 census. Between that same 2016 and 2022 time period mentioned before, there was a 240% increase in the rate of emergency department visits due to opioid-related poisonings, whereas Ontario saw a 150% increase in that time. Similarly, Windsor saw a 40% increase in the rate of hospitalizations due to opioid use complications, whereas Ontario, the rate of hospitalizations kind of stayed flat. And finally, the death rates in Windsor, Essex, due to opioid-related complications was increased by 120%, whereas Ontario had a 200% increase. Though in recent years, the rate of opioid-related deaths seems comparable between the two, with Windsor at 20 per 100,000 and Ontario at 19 per 100,000, respectively. And as for the rates of opiate substitution therapy, Windsor, Essex saw an increase in the rate of people on OST from 6 per 1,000 in 2016 to over 7 per 1,000 in 2022, so around a 26% increase, whereas Ontario saw a rate of 4 per 1,000 in 2016 up to 4.5 per 1,000 in 2022, just under 10%.
So this is just denoting our hospital service. We have 4 physicians that take call about a week at a time, and we cover all 650 beds in the hospital, although we've never been called to pediatrics, thank goodness. And we are primarily there to help the folks stay admitted, to deal with their complications of opioid use disorder, so help them through withdrawal, and offer them opioid substitution therapy in the form of Suboxone, methadone, or morphine.
All right, so for our study, we're interested in looking at how often patients who have opioid use disorders are referred to addiction medicine when admitted with medical complications, and we were interested in what the outcome of those consultations were. So our initial thought was that there would be a significant difference in the hospital stay outcomes between individuals who were connected with addiction medicine versus those who weren't. So we conducted a retrospective chart review looking at individuals who were presented to Windsor Regional between January 1st, 2019 and December 31st, 2021. We looked for people who presented with medical complications as a result of significant opioid use, using the ICD-10 codes for common complications of opioid use disorders, and also selected for individuals who had a previous documented history of opioid use disorder. The ICD-10 codes are shown here. We used 2 independent reviewers who reviewed patient medical records, and data was captured, recorded, and analyzed in UWindsor's REDCap. Patient charts were analyzed for any available demographic data, including age, sex, ethnicity, housing status, employment status, and family and social support. We also collected the gross number of ED visits in that 3-year study window and the total number of admissions, including what team they were admitted to and the primary reason for admission. We also used the Charlson Comorbidity Index for each patient in order to categorize the severity of each patient's comorbidities. So for the CCI, severity was categorized as mild for a score of 1 to 2, moderate for a score of 3 to 4, and severe for a score of 5 or more. So for patients who were admitted, we further looked into whether any referrals to addiction medicine were placed before being discharged, and if they were placed, what the outcome of those referrals were. So for example, if they kind of refused the consult, if they had OST recommended, but the patient declined, or they started OST before leaving hospital. And finally, we did some preliminary comparative analysis to look at the differences between the groups who were connected with addiction medicine and those who weren't, though a full statistical analysis is still pending. So this is a preliminary presentation.
So out of that 2-year study, we found 32 participants. It doesn't really reflect the number of patients seen by the addiction service. About half of them were female and half of them were male. Half of them were working, half of them weren't. The oldest was 70, the youngest was 25, and the average age was 42. This slide denotes the number of ED visits for these 32, 511. Most of them being less than 10 visits, but 2 outliers with more than 40 and more than 60 visits, 2 of them. On the right side, this denotes the number of admissions of these 32 patients. And what it took to get a referral to addiction medicine generally was a lot of admissions. Yeah, next slide, Zayya. So of these 70 admissions, and we ended up with 13 referrals. The left side of the slide denotes the different services that they were admitted to. So 38 admissions to internal medicine with 6 referrals to addiction medicine, 7 referrals to family medicine, 14 to intensive care with 2 referrals each, etc. And the right side just denotes the different admission diagnoses. Next slide, Zayya. So this slide reflects the admissions with referrals and without referrals, which was statistically significant. So you needed a lot of admissions to get a referral, as noted from the previous slides. Also, you needed a lot of emergency room visits to get a referral, 22 emergency room visits before you got a referral. This goes along with an admission, of course. And your Charleston Comorbidity Index was significantly higher if you were referred, 3.5 versus 2.7. And you were more likely to leave AMA if you were referred to addiction medicine. Back to you, Zayya.
All right. So when we were reviewing the charts, we noted that across the various inpatient services, there appeared to be kind of a lack of consistency in how often the referrals to addiction medicine were placed. So like Dr. McKay mentioned, of the 70 unique admissions, only 13 had referrals to addiction medicine. And these referrals appeared to be made based on the MRP's clinical judgment, and we couldn't really find a standardized reason or approach across the 13 that helped kind of guide the decision as to who or when a referral to addiction medicine was being made. This could suggest that there may be a need for a standardized method to find patients who would benefit from being seen by addiction medicine earlier. And of these 13 cases, 10 had indications for opiate substitution therapy and had it started while admitted. So while these are limited numbers, there was a large proportion of them who benefited from being connected by addiction medicine. This could suggest that there's a fair amount of inpatients who are being missed and who would otherwise benefit by being connected with addiction medicine. And finally, the high number of ED visits, we saw maybe an opportunity to have patients connected to addiction medicine before the need for hospitalization occurs. And if the opioid use disorder can be better managed in the earlier stages, we may be able to limit the degree of medical complications that arise later down the line. So in terms of some of the limitations of our study, the patients we selected for this review were only those who presented to the emergency department with medical complications secondary to their significant opioid use disorder. These individuals were more sick and burdened by their opioid use disorder. We did not review patients who presented with uncomplicated opioid use disorder. In a similar vein, the ICD-10 codes we used were focused on the medical complications and didn't include psychiatric conditions. And this likely excluded a large portion of patients typically seen by addiction medicine, and therefore limited the power of the study. So both these populations would offer a larger sample size and allow us to better assess the true referral rates and outcomes of addiction medicine. And that's kind of into our next steps of our project. So we're in the early stages of a new branch of this study, which is geared to look at individuals who are admitted to psychiatric services alone and the rate of referral and outcome of addiction medicine while in their care. And then further into the future, we're interested in looking at how early addiction medicine connections in the emergency room may impact the patient care and course in hospital. So on behalf of Dr. McKay and myself and the rest of our study team, we want to thank you for your time and the opportunity to share a little bit about our studies. Thank you.
Thank you, Zayya. Thank you, Robert. Do we have any questions specifically for this team? I'm just going to jump into the chat. Let's see. Trish had a question. She said, I missed who was doing the referring. Who were the folks being referred by social work or pharmacy or the MDs?
Yeah, medicine, whoever the MRP was. Yeah.
Okay. I had a question. Oh, hang on. There's another one. I have a little trouble seeing the hands and the chat at the same time.
It's Tim. Tim is.
Yeah, oh, okay, Tim, go ahead.
Hi, this seems like this is a really great study. I'm very intrigued by your finding and the comments you made that it's not seeming to capture all the people that you actually saw as referrals. Do you have a sense of kind of like how many you would have anticipated? Like what would have in this time period been maybe a more accurate number?
The referrals, I think when I'm on for a week, it's 4 or 5 referrals anyways a week. So I think a lot of those are psychiatry, right? So, and a lot of those are uncomplicated. So,
And are a number of those for alcohol use disorder versus opiate use disorder? So it's only like a certain portion of that would actually be relevant to the study?
There's a few alcohol use disorders, but the psychiatrists, they wanted to take ownership of the alcohol use disorder. So So they said, you're not getting those ones. I said, that's fine. It's fine. You can keep them. So, yeah.
Yeah, that does lead to more questions.
Yeah.
I had a question. The numbers that left AMA was higher for patients with a referral. Do you think that possibly that's a reflection of the severity of those patients? Like more likely to be opioids, for example, and more likely to be severity of illness. Yeah. That's a tough one to parse out. Yeah. Thanks.
Yeah, for sure.
All right. Well, I don't see any more questions. There's nothing else in the chat. So thanks to Zayya and Robert. I'll have you guys step down. I'm gonna introduce Trish. Welcome, Trish. Where's the real you?
There we go. Thanks. I don't know what happened. Oh, there we go.
I'm just teasing. Thanks so much. So
Okay.
I'm just going to introduce you. Trish Uniac is a rural generalist working in Huron County. Her practice includes full spectrum family medicine with a special interest in addiction medicine, particularly as it affects healthcare workers and first responders. She's been working with healthcare professionals with substance use disorder since 2013 and speaking about the care of physician mental health since 2010. Thanks, Trish.
Thanks. I'm just trying to get this. I apologize. I had everything all ready to go. And as always, oh, for Pete's sakes. Okay. I'm hoping that you guys can hear me okay. Of course, as soon as I got over here, everybody else decided to join me, which is not fantastic. So here we go. So I'm going to be talking about helping the helpers when healthcare workers develop addiction. So I have previously received honoraria for speaking on behalf of the Wellington Addiction Services and the Grand River Hospital Psychiatry Day. I don't really have any biases that I need to mitigate. I'm not going to make any treatment recommendations. And so here are my objectives. Okay, we're going to learn how to identify warning signs in our colleagues, know why treating substance disorder in healthcare workers is different than it is for the general population, and talk about how to mitigate risk to our colleagues working in addiction and elsewhere in healthcare. So as soon as I say that, I'm sure that most of you are going to be worried that I'm going to ask you to take care of your colleagues as well as your patients and all the other administrative burden that you already have on your plate. And you're right, but it's not going to be as bad as you think. It may even reduce the burden that you have now and in the future. When we're in training, we are told that we're supposed to treat all of our patients with empathy, but we're also taught that we only have a fixed amount of compassion that we're allowed to share. If we go beyond that, then we don't have any left for ourselves. This battle of narratives can be literally painful and can cause burnout in us. What we know, though, is that on the days that we make real connections with our patients and with our colleagues, we have much more energy at the end of those days. So I just want to quickly explain the difference between empathy and compassion. So imagine that there is a fishing boat offshore. Okay, you're standing on the shore and you see that there's a storm coming up. Empathy is when you swim out to help that person in the boat get back to shore. Your skin is in the game. If they go down, you go down. You feel their pain as your own pain and endure their stress as your own pain response. Compassion is when you acknowledge that the person in the boat has the skills that they need to get the boat back to shore. It's what they do. It's their job. Compassion is making sure that the lighthouse is lit. We're starting a fire on shore. We're witnessing them arrive and helping them if they need us. But we're there to witness. We're safe and we're there to support only if they actually need us to. They feel better knowing that we are there. And because of the way that those reactions are, the compassionate interactions light up our reward system in our brain. Okay, so figuring out how to identify a colleague that's in trouble. None of these should be too surprising. Physical, they're always tired, they're jumpy, appear on edge, they have red eyes, impaired coordination, the things you usually get used to seeing with different kinds of withdrawal, like rhinitis, yawning, tremor, that sort of thing. Behavioral, you might notice that they're irritable, defensive, they're late to work, they have absenteeism, depression, anxiety, they just hate their job. They're complaining all the time that they can't get enough sleep, that they've got money problems, they seem to be withdrawing from everybody at work and trying to isolate, or they're just picking up extra shifts. And if you're anything like I was in residency when I learned about that list, you're suddenly worried that everybody at work thinks that you have addiction, because most of those, I would say, show up as this. So all of this list can show up in those ways. So is it addiction, or is it burnout, or is it a mood disorder? Is there problems at home, including domestic violence? Does this person have PTSD? Is there overwhelm? Do they have an eating disorder? Like, there's something is going on though. So for the most part, we can't tell which it is without doing a formal evaluation of our colleague, which is not our job. It's not what we're supposed to be doing. Our role is to be a compassionate colleague. So just ask. The one thing I'm just going to mention, though, kind of quickly, is that for folks that have an opiate use disorder, they're going to be much more likely to pick up extra shifts rather than avoid them. Also, those with PTSD and OCD and anxiety. Those with alcohol use disorder are more likely to be later absent, but also depression. So not too shocking that way, I think. So because of the way that our brains work, we assume that the entire world sees everything around us the same way that we do. And almost every single patient that I meet in my healthcare worker addiction clinic truly believes that nobody at work has noticed that something was wrong. So if you're seeing somebody who's demonstrating any kind of behaviors you're concerned with, just letting them know that you're worried will flag for them that they're not acting themselves, and it offers an opportunity for connection. It's a lot better to say, are you doing okay? I've noticed whatever the thing is that you've seen, when we do approach our colleagues, instead of you've been late at least once a week for the last 6 weeks, which can feel pretty judgy. Those that are struggling with addiction are much less likely to hide from getting help because of the shame. So I'm going to try to argue that healthcare workers with addiction are different than the general population. Just going to mention really quickly, I tried to do a lit review to catch myself up to see what was new since COVID, and there is still an absolute dearth in this field. People are not doing research on healthcare workers with addiction, which is really unfortunate. So a lot of my patients will say this to me, that it wasn't the addiction that almost killed them, it was the shame. And there's lots of reasons for that. As healthcare workers, we are indoctrinated to think that we know better, that we should be able to avoid developing addiction, because we've got these two sets of standards. You know, there's the one for our patients where we have compassion because we know that they have a disease. And then there's the one that we have for ourselves where we feel like absolute garbage if we are ill, because we're supposed to know better. Even if we're ill with something like the flu, I know so many people will get really upset with themselves for letting themselves get sick. Our medical training, no matter where we're trained, if it's as a physician, as a nurse, social work, all of it, tends to be very shame-based. So it does tend to be our go-to response. So I think it's important to remember here that the shame is that emotion that signals to us that we're about to be kicked out of our community because we're defective. So the instinctive response to shame is to hide away so nobody can see what your mistakes are. It seems to be even worse for workers that I meet that are working in safe use sites. and in addictions, because they take their status as role models very, very seriously. When I'm getting these folks back to work, I usually want them to have at least 5 years of sobriety before working at addictions, because I'm trying to protect them from relapse due to triggers, stressors, shame, temptations. Those who do relapse while working in addiction and mental health become incredibly unwell because of the shame that they end up feeling. For some folks, their dealer is going to work is like walking into a candy shop, only instead of the vending machine that we had at the high school cafeteria, we've got a Pixie machine, Pixis machine that gives us those tasty treats. Our sense of what's normal becomes very off when we work in healthcare, especially because the way that our patients tend to talk to us about their addiction through their rose-colored glasses. They think that, they're drinking a bottle of wine at night. They think that that's pretty normal. So if I'm only having 2 glasses of wine at night, that's got to be fine. We have intimate knowledge of how medications work and what they do for our symptoms. A lot of the nurses that I speak with start drinking because they were told by their colleagues it would help them sleep. Gravol and Benadryl get misused quite a bit. To be fair, just like they do on the floor. If there's a PRN available for Gravol or Benadryl, staff will often use that to help sedate patients. So a lot of us end up seeing healthcare as a calling rather than a career. So this is an exercise that I used when I used to work at Homewood with my healthcare workers. So I would get them to fill out this map with all the different parts of who they are, to find out where we can increase their overall health. So I would call these the 5 pillars of health, that we were trying to have good, strong health in all of these spheres: intellectual, social, mental, physical, and spiritual. And very often I would get back something that looked like this, where they were able to say that they're a spouse and they're a doctor and they had nothing else going on for them. And this can be devastating, because when a healthcare worker is told that they are being taken off of work because of addiction, that they may lose their license because of professionalism issues, they don't know who they are anymore. And so many of the folks that I speak to are quite suicidal, and we're lucky that we keep them alive if we're able to the point that I get to help them out. Because the consequences from our colleges are so strict and substance use disorders are so taboo in the health sector, the sense of shame is multiplied even more than it already should be. People are hiding a lot. So we always talk in my clinic, my addiction clinic, about wanting a quick fix, wanting to shove our emotions down. We know that those are really common addiction issues, and it's something that we're taught to do in our training, right? So we are not supposed to show emotions at work. We're supposed to suppress them all. Works really well, so we start to do it at home. But eventually the emotions do pile up, and suddenly we're turning to substances to help us instead. So what can we actually do about it? And, don't throw parties that have lots of alcohol at them. It's pretty basic. Don't give everybody alcohol for Christmas. Encourage behavior. So we want to have a quick fix for all of our patients as well, because it's nice and easy. We can give them a bit of Benadryl, they go to sleep. They're no longer bothering us. Encouraging behavior with our patients helps to role model to the colleagues that we're working with that that's something that they can be doing as well, just to give them a different solution. Debrief often. We have bad days. Grief is real. We feel grief for our patients, even though we're told that we're not supposed to. Going home with big feels is not healthy for any of us. So leaving work at work is the healthiest. We can do that better when we debrief. And finally, walk the walk. Try to sleep, eat, move, and speak the way that you know is living a life of recovery. Be open about how you're feeling. Acknowledge your emotions. Maybe say how you're dealing with it, and then move on. And that is that.
Thanks, Trish. That was excellent. I just knocked myself off the stage. I didn't know you could actually fall off the stage, but I did just now.
Nice.
Yeah, somehow I just
Excellent.
fell off and I had to get back on again. I'm just looking. I don't see any questions. I'm looking for hands. That was really made me think, because who do you know that's a healthcare worker that doesn't take it home, that doesn't go home with, as you said, big feels, right?
Mm-hmm.
And we don't, I would guess the majority of the time, we don't have the luxury of perhaps having colleagues we can debrief with. I mean, I get into my car maybe or onto a bike and I play loud music, but
Mm-hmm.
I don't have that. And I think I wonder if we can, it makes me think of how to build some more of that, because if I look at my assistants and administrative and other people that we work with as well, they probably need exactly what we need.
This is it.
Which is that moment.
And that's where the role modeling gets to be so important. It's the culture now where I work that everybody expects to debrief, because we debrief everything. I had a physician call and had my nurse crying because he was having a bad day. So we debriefed that, right? Like pretty much everything, because it makes the rest of the day go a little bit better. It doesn't take that long. Like we can do a good debrief in less than 2 minutes.
I think I only do it with my workers on a PRN basis. Like if something's, oh, you look like you're having a really bad day. Do you want to talk about it? Pop in at the end of the afternoon, but not routinely, so that it's just an opportunity to the goods and the bads together. So Diana had pointed out that we have a very toxic healthcare system, which puts providers at risk of mental health problems.
Absolutely.
Jennifer's asked, do you pre-book time consistently? I think you mean for like a debriefing period.
I don't. No, we definitely, we do it as a PRN basis, but I think that we need it all the time. So
kind of reflexively.
Yeah. Yeah. It's just kind of known that we're going to debrief at least. If I'm working an emerge shift, we'll be debriefing at least 5 times during my shift.
Really good. That's great. I'm going to ask our other speakers to come back up on stage.
And
I have our audience I've unmuted. So if somebody has a question for anyone, you can put your hand up and I'll either call you, or it looks like there's not a lot of questions all at once. So you could just push the button and speak. I wonder if it's maybe our perspective and bias the way we look at things, but I seem to be getting the feeling, and again maybe it's the context being Medify, that there's much more, and I don't think buy-in's the right word, but much more engagement and involvement of people who work in the hospital and the emergency room in terms of community, seeing their role in community addiction care. It's just an observation. Oh, and I'm sorry, I'm having a little trouble with my audience view here, but I see a speaker on, so somebody's pushing on their speaker. Go ahead. I think it's Tim. Is that you? Maybe not.
I think that was Geraldine, maybe.
I don't have a way to go ahead.
Hi, it's Carrie Lynn. That was a bit ago. I just wanted to say that I love the idea of debriefing. And it can be a challenge because certainly in our clinic, you have everybody running 18 different directions. You know, trying to figure out how to do that is a great idea because I think we're all sort of hanging on the edge some days. So I'm definitely going to talk to them about that. Thanks.
And it's true, like, I don't know about the rest of you, but I kind of feel like I have almost like a literal shield in front of me all the time at work because I'm so afraid that somebody's going to need something from me.
So you mean when you say and that somebody would need something from you, do you mean like a colleague?
Yes, yeah, like a colleague.
Like it's going to get in the way of, you know, your
Yeah.
agenda for the next hour?
Yeah, like if I actually make eye contact, then they're gonna they're gonna have a bad day that they want to tell me about.
Yeah, or
yeah, totally slimy.
Standing at the front waiting for something.
I guess you've put yourself in harm's way, Trish. So
yeah. It's true.
Now, are my speakers able to see the hands up? Are you guys able to see who has their hand up?
Diana
Looks like Jennifer. And okay, go ahead, Diane, and then Jennifer.
Oh, do I just hold the button and talk?
Yes. Yeah. Hold your. Yeah.
Okay. No, I wanted to expand on my comment. I think debriefing is great, but I think everyone needs to understand what debriefing looks like. And I think what tends to happen is this term that I learned called sliming. And this actually just happened to me yesterday at the RAM, where I had actually just finished a very intense emotional session. And then a colleague came in and said, "Oh my God, you won't believe what just happened." And then just like told me the most awful, traumatic, you know, experience that she had had with a patient. And I like no preparation, no kind of, is this a good time? I think she just needed to share it with someone. And then all it did was like totally dysregulate me. And I didn't have time because I had to go into the next patient. So I think, you know, we just need to understand what debriefing looks like, because it's not just going to your colleague and like dumping a really awful experience on them to get it off your chest, because then all you do is pass on the trauma, right? So just wanted to share.
So just thrown like what my formula is for debriefing based on the literature review that I did, I don't know, like 10 years ago, that seems to work. And I can pop through that really quickly.
Yeah, that's helpful.
Mm-hmm. So just look at the facts, just exactly what happened. Talk about what went really well, what went really badly, what we learned, and then try to find any silver lining that you can.
And like, do you facilitate that, or do you have like a designated person that debriefs, or can anybody do the debrief?
I tend to do it just because I've got it just memorized and ready to go. But when people go through it enough, then they'll do it themselves. So I don't need to be called in all the time.
That's great. I'm writing all that down. Thank you, Trish.
You're welcome.
Jennifer has her hand up.
Thanks, everyone. All great sessions. I want to look back to Kira's presentation. And Kira, I'm putting you a little bit on the spot. I'm not asking about the buprenorphine implementation so much as for your perspective as a resident, so a relatively new physician entering the field, and wondering a little bit about your perspective on the interest and openness of your peers to address substance-related issues, because I think in the past, you know, addiction medicine was considered to be something separate, and you know, not really the purview or the responsibility of clinicians, whether they were primary care or emergency medicine. And I'm hoping that what we're seeing is a shift in attitudes around whose quote unquote responsibility people with who use substances are. And just wondering if you could share a little bit about your thoughts on what you're seeing. your perspective in those, as I said, of your peers in Emerge particularly, because I know that's where you are, but maybe a little bit more generally too.
So I think the times are changing. I'm here in Kingston right now. We have a room full of staff and a couple of residents as well. I think my generation of physicians understand this to be a medical problem that needs to be addressed medically. As mentioned in my presentation, we kind of had grand round sessions here in Kingston, and those were heavily attended by residents. We've had lunch and learn sessions, again, heavily attended by residents. Unfortunately, when I went through medical school, I don't remember any teaching sessions on substance use disorders. So it's kind of been on us to learn about that through other resources. And I think when those resources are being made available to the residents here in Kingston, a lot of people are recognizing how important that is and taking time out of their limited free time to attend these sessions. As mentioned, we've got a couple residents here in the room on a Saturday afternoon. So.
Thanks so much.
Thank you. And thank you to all of our speakers. Zayya, Kira, Robert, Trish, really appreciate the session. I'd just take a moment to ask people to just take a second to hit the link in the chat with the feedback for this session. And then we'll be on a half-hour break until 2:30 for our closing session.
Thanks for your help, Lori.
Thank you.
Appreciate it. Yeah.